Everyone, welcome to the HCBiz show, episode 31. Sorry for the delayed start, but we've got our technical difficulties worked out and everybody's on board. Thank you so much for joining us and thanks for your patience. This is the show where every week we break down the issues and opportunities facing the business of healthcare. We try to dig in to identify what they are, why they haven't been solved and or taken advantage of yet, and try to send you all away with some actionable info that you can start doing something with today. I'm your host, Don Lee, and joining me as always is my co-host, Shahid Shah. Shahid, we've covered MACRA a couple of times here through the proposed rule and the comment period and everything else. So it's here, it's real, it's official. So I guess in setup, my question for you as a practitioner of solving problems, a practitioner of business, if you're a doctor and you haven't yet gotten going on this, you haven't started to wrap your head around it, what are you hoping to learn right now? What do you think they should be focusing on to get started?
Yeah, hi guys, great question to start us off, Don. I think really the thing to think about is, are you willing to lose 2 to 3% or 4% of revenue over the next few years? If so, and you're about to retire soon, don't give this a second thought, right? It's a matter of you being ready to say to yourself that this is, if you're not ready to say it's real, then you're going to try to trick yourself into thinking, oh, I'll just deal with it later. But you have to start. If you're not ready to go now, I recommend that you take a look at your budgets and say to yourself, what happens if I take a 3% hit or a 4% hit top line from my Medicaid reimbursement? And if that doesn't mean much to you, then by all means keep waiting. But if you're a large enough shop, that could mean a lot for you. So you now want to make sure that you're very cognizant of what's going on with at least MIPS, the MIPS program, as opposed to MACRA first. So look at MIPS, see where you fit in. And those are the kind of questions that we'll ask Aisling here real quick to see, does she agree with that assessment? Because we like to tell people just kind of like practical things that, if you're a few years away from retirement or you're looking to sell your practice, what should you do? If you're in mid to long term, looking at your career, what should you do? And if you just don't know what to do at all, where should you go doing some research, et cetera. So we're really thrilled to have you here, talking about the new rule that dropped on Friday to tell us, are we right in these kinds of advice that we're giving, or should we be giving people advice in different ways?
Excellent. Yeah. So with that, I'd like to welcome our guest, Aisling McDonough, spokesperson from CMS. Thank you so much for joining us on very short notice, almost no notice. We just stumbled into each other yesterday, as a matter of fact. And I appreciate you coming on and talking to us about MACRA.
Yeah, thanks for having me. We dropped the rule last Friday, and we're very excited to spread the word and kind of give people the actionable information that your business or your show focuses on. So I'm excited to be here and excited to give some advice.
Awesome. Well, you guys have been hard at work now, and I'm sure it was a blitz right up to the end there. So congrats on getting it done and getting it out. Really, I'm personally very impressed with the quality of the materials that are coming out right out of the gates here. The QPP website is great. A quick way to get in there and understand what's going on if you're, again, a doctor and you need to start getting your arms around this, and a lot of the other supporting materials that are out there. And the response, at least so far, seems to be pretty positive. What are you guys hearing at CMS since Friday, since you started rolling all this stuff out?
Yeah, so we've been happy with the response, and we've been happy that people felt like we listened to them. We received 4,000 comments, which is a huge number of comments in a proposed rule. And we had events all across the country where we had both on the ground and virtual events, over 100,000 or nearly 100,000 people join and talk to us about what their experiences have been in, the prior CMS quality reporting program, so the Physician Quality Reporting System, PQRS, and also their experiences with meaningful use. And we took those down. We also took their requests and comments about the proposed rule and tried to incorporate those. And from what we've heard from, just everyday clinicians, as well as medical associations and from Congress who created MACRA, they felt like we listened to them and that their comments got incorporated. So that was our goal. We're happy to hear that people thought it. The second item I would say is that we dropped the regulation. That's that's typical business, but we try to go outside of typical CMS business practices with this this rule, knowing that people felt were nervous about what MACRA meant, what the changes were, and so we try to incorporate it through kind of a broader, bigger movement within CMS, providing clear materials. The new website, which is qpp.cms.gov. We have a call center if people have questions about that, and you can go to the Learn Education page of the qpp.cms.gov page and find the call center down on the footer. You can also submit email questions. We're doing kind of the social media blitz. Our administrator, Andy Slavitt, was on a Politico podcast that I can link to during the tweets where he discusses what the work we've done. And the second item that we actually did was the day before MACRA dropped, the administrator made the announcement that we're starting a new initiative where we're going to better connect with clinicians in the field to hear what is the regulations that are really holding up their practice, how can we better streamline them, and what can we do to reduce burden. And that's run by one of the practicing clinicians in our office in CMS, Dr. Shantanu Agarwal. And his first action in this initiative was to announce that for people who are part of certain advanced APMs, that they won't have to be subject to medical review. So that was a big deal. We announced that on Thursday last week. We're going to continue kind of taking those recommendations and trying to reduce regulations and burdens so that people can get back to being doctors and taking care of patients.
That's actually pretty big news, Aisling. So tell us a little bit more about that. So what you said in like one passing sentence is actually huge. You said that alternative payment models do not require medical review. Can you talk a little bit more about that?
Yeah, so we have a fact sheet that I can share when we get to the Twitter chat. But basically, for certain advanced APMs, we're doing a pilot program where medical review will be drastically decreased. Of course, if we hear some sort of concern about patient safety, it'll kick back in. But other than that, we think because of the certain requirements of advanced APMs, we thought it was kind of a low risk area where we heard concerns about the paperwork and about medical review, and thought, well, maybe we can do a pilot and try and scale it back to because we heard the concerns.
That's actually pretty nice. So one of the things that always stops up innovation is that requirement for medical review. So I really like that idea. So tell us a little bit more then about the big differences between what the final rule is versus the proposed rule. So we have a lot of material about what the detailed differences are, but from a practitioner perspective, a physician who is literally, like you said, practicing medicine, what should they be concerned about at this point? What should they be looking out for? So we're telling people it's real, and we've been telling them for months that this is not one of those small things that you can just kind of like brush on the side. This is bigger than meaningful use was. It's bigger than most other things like accountable care organizations. This affects literally everybody because it's a replacement for the doc fix and other things that have been going on for a long time. So tell us, looking at, just let's pick one target audience, small to medium-sized physicians groups. What should they be looking for in this rule, and what should they care about?
So yeah, I do really want to hit on what small practices should care about. One of the biggest comments that we got during the proposed rule was, did we have enough support for small practices? And the changes that we made with the final rule was, one, to raise the low volume threshold. So that's getting a little jargony, but basically what it says is that if you see more than 100 Medicare patients a year and receive $30,000 or bill Medicare over $30,000, then you're in the MIPS, or you can be part of advanced APM. If you don't see 100 patients, or if you don't bill $30,000 to Medicare each year, then you're not in the program. You're exempt. And based on our analysis and our estimates, we think that about 50% of small and solo practices, so under 10, will be exempt from the program. So I think that's a huge part. A second part is that we have $20 million each year for the next 5 years, so $100 million total, to provide on-the-ground help to small practices. To we're working to hire organizations to literally go to the small practices and show them step by step. Here's what you need to do. Train them so they're ready for it. And I think the third big change for the final rule for small practices and for everyone, frankly, is what we're calling this pick your pace. We announced it actually before the final rule came, which was a little bit outside the ordinary, but we wanted to do that because we had heard so much anxiety and concern about this first year and getting ready that we wanted to address what to expect on the January 1st, 2017 start date. And basically what to expect is that if you're ready on January 1st and you want to do a full year reporting and you've been doing PQRS and meaningful use for a while and you feel ready, then go ahead and get started. But if you don't feel ready, you have up until October 2nd, so 90 days before the end of the year, to truly start, and then you can do a 90-day reporting period. And both those ways, you could, it will make you will be eligible to receive the full or the maximum MIPS bonus payment. So I really encourage people to look at Pick Your Pace. I've been tweeting at the executive summary, which details it often, but want people to be aware of that. And I would say the third thing about Pick Your Pace is if you've never done meaningful use, if you've never done PQRS, and you're just brand new to these kinds of programs, then you can avoid the negative penalty pretty easily. All you need to do is pick a quality measure or even a improvement activity and report that to CMS, and that'll get you over the threshold and you'll avoid getting the negative payment adjustment. The main way to get a negative payment adjustment is to not do anything, not participate in the program. So even if you're talking to people who are thinking ahead that they're gonna not be practicing medicine for much longer, I would still encourage them in this first year to really participate and just test the system, see how it works. And a common phrase we said during ICD-10 was that it's easier than you think. I think this is going to apply here too. You can do it, you should, and not only will you avoid the negative payment adjustment, you could be eligible to receive additional money, so you don't want to miss out on that either. Plus, gathering more quality data, we are hoping will help understand better how to transform clinical practices.
Right. And related to that, if you think about the way that we've been talking about MIPS and MACRA, it's mostly about reimbursements and things like that. What have you guys heard where how physicians or other small practices been telling you, yeah, if I follow what Medicare is asking me to do for MIPS and MACRA, it will actually improve patient care. It will actually give us better patient satisfaction. Because I get the feeling, and when we hear about it, especially on our talk show fairly regularly, is that the doctors are doing this because someone is making them do it, and they don't see any real benefit to their patients or their practice, et cetera. I'm sure you guys have given significant thought to that problem. What have you come up with on the Medicare side to talk about that?
So one category, and it's new, so people are concerned about it, is these clinical improvement activities, and those are part of the law. They're part of the statute. And if you go to qpp.cms.gov, you can see more about what those activities are. But they include things like telehealth. They include things like having your practice open 24/7 or having a call line available, doing site visits for your patients. Typical things that where Medicare traditionally, it wasn't a code, it wasn't something that you could do for fee-for-service. Now you can claim those, or not, claim I shouldn't say, but now you can get credit for those through the MIPS program and get paid money for it. So what we're trying to do is move away from fee-for-service, where you have to figure out the specific activity or product that you're giving the patient and receive the reimbursement for that. And instead, move to a program that supports you in kind of the full spectrum of work you do for your clinician, for your patients, so that we're paying for what people value, which is, I think, coordinated care that's available. Information exchange between patients and their doctors. So that's another part, is the advancing care information, which is the tech side of MIPS, is really supportive of. We took it down from 11 required measures to 5 required measures. So there's only 5 items you have to do in advancing care information now, and they're purely focused on patient engagement and exchange of information. And I am plain language. I'm in the communications office, so I don't like to say interoperability because I don't think it is a real word. But you know, exchange of information between patients and their doctors, and between doctors themselves about a patient's information. You know, the other required area for advancing care information is, you know, doing security for your electronic health record, which we think is important and can you know, protect patients as well. So that's on the MIP side. I think there's a ton of you know, benefits for if you're a patient who's in an alternative payment model. So if you're part of an accountable care organization and you're receiving care through a coordinated care team who is tracking, you know, has a primary care physician who's tracking your progress and seeing how you're doing, and talking to their other doctors. I mean, anyone that you talk to who's had, you know, a long experience as a patient in the care system knows that it is a lot of effort and work to try and keep your records straight and keep your treatment straight. Having that extra help and having that extra time that your clinician can spend with you really makes a difference, and that's what we're trying to push for and reward people doing that.
Yeah, that sounds great. And Don, I'll turn it over to you in a second. It sounds like I heard 3 really interesting things that piqued my eyebrow here. So if you think about the first part, which was that not all alternative payment model features require 100% medical review, that's a big deal. The second thing we heard was that there are things that practices may want to do because it's the right thing to do. Yep. Those may now be credited. So it could be telehealth, it could be other areas. And the third part is you could be credited for things you're supposed to be doing anyway, which you could be fined by OCR, which is things like cybersecurity, risk assessment, and things like that. So if you're not doing a risk assessment, you could, in theory, be fined by, if you get an audit from OCR, you could be fined for not having that, not passing that. But if you do it, it actually allows you to get credit for it in the MIPS program, it looks like. So those are actually 3 big, very good reasons to say that if you have ideas for how to do things the right way, you've got some new things that you want to do in the alternative payment model schemes, bring it to bear, because it doesn't necessarily have to have 100% medical review. If you've got some things that you're doing that really do affect patient care and can impact it because it's the right thing to do for patients, not that it's because the government is telling you to do something, definitely go for that, because you'll get bonuses for it. And the third thing is look at stuff that you're supposed to be doing anyway, which you could get benefit for. And there seems to be now all kinds of good reasons to make sure that even practices who are not looking to stay long in business or might be wanting to sell out and get merged or get acquired by someone else, seems like a good place for them to be able to do some research as well.
And just one more point on the government telling you things to do versus what you think is right for your patients. I'll say that CMS does not just make up quality measures. You know, we don't sit around in a conference room and be like, it'd be nice if we made them do this. We work with, specialty societies, individual clinicians, experts who are part of it, the National Quality Forum, to create the quality measures and to test them and to have evidence behind them. So that's one point. And for the new practice improvement activities, so the ones that we're going to give you credit for the ones that are going to give you credit for, telehealth or taking Medicaid patients or, doing behavioral and mental health services. Those were created based on people's individual clinicians' input on this is how my practice is organized, this is what we're doing in the field, and this is what we would like to get credit for. So just wanted to make that kind of clear point that it's not. We went to clinicians and we went to specialty associations to understand what's the right thing to do here. And if people feel like there isn't the right thing there, let us know, and we're going to continue developing the measures, and we're going to continue developing the activities, so you can get involved. Yeah,
and I think that last piece is very, very important. Is that so? One of my jobs is as a subcontractor to a number of government agencies. We see this often is people just believe, well, that you guys are sitting around in an ivory tower, big boardroom, and saying, hey, how can I make my life more miserable for everybody who needs to work with CMS? Of course, that's not the case. But what happens oftentimes is that these kinds of rules, they come out, and the small to medium-sized practitioners don't feel that they have a voice in complaining about it in any other way other than, jumping on a Twitter or something else. And what we've noticed is Andy, specifically, your boss at CMS,
Yes.
actually is willing to listen to people, even if they complain on Twitter, bringing them out, having conversations.
Oh, yeah.
The one thing we recommend to all of our listeners here is when you have a complaint, this is relatively new. Somebody's actually listening over there, whether it's a social listening on Twitter and other places, or if you send an email, or you want to come in and visit, have a meeting and really air out what you're doing. So if you're part of an independent physicians association, you're part of a group of physicians where you're an influencer in that team, we need to actually take it on our own responsibility and our own shoulders to say, this is real, right? I mean, moving from fee-for-service to value-driven care is not an experiment anymore. This is now set. This is now regulation. We're going there. Now, how well we get there depends on us as an environment, as an ecosystem, as a team together. Now, the government has its part to do in leading that for sure, and they've done their part here. But now really it's our part to say, how well will it work? How can we make sure that we get our learnings back into the government's hand? And then we can blame the government if, for example, later we give a lot of input and nobody listens, then we have some reason to complain. But I've seen a lot of change just in the last couple of years where there is active listening going on and things are being adjusted because of it. And, we just saw, for example, the drug agencies taking some major input from the customers and taking input from citizens to say, no, this should not be a controlled substance, and them rolling that back because input came in waves, not just one or two people complaining about it on Twitter, but official channels saying, no, this is a bad idea to move this drug from a uncontrolled substance to now a controlled substance because there's no reason to do it. So people are listening. So I want to make sure that I know, Aisling, you're from the government, and people don't often believe people from the government as being there for them. But really, I can see that here, as a party looking at both sides, is you are listening, which is great. But as we go forward, we've got to figure out, maybe even this is a responsibility for us, people like Don and myself as technology folks, is how do we put telemetry systems in? How do we put in systems that can watch what's going on in the industry, roll that up into aggregate sentiment analysis and other things, and then potentially feed that back to the government to say, hey, here's what's really going on. Here's how people really feel about what they're doing. And that might be something useful over the next couple of years as well. Don, I'll turn it over to you.
That would be great. And actually, we're working with the USDS, so the United States Digital Services, which is something that President Obama created to bring better, technology practices to the government. And that's one way that we're getting we're creating what we call user-driven policy, so that we are we're actually listening and taking that response. And the rule's over 2,000 pages, but almost, I think 70% of it is us responding to comments that people submitted, and there were 4,000 comments, so it got a little lengthy.
Great, guys. So we're running a little bit long because of our late start. So it's, I want to get to a couple of questions that came in from the audience here. And the first one, Aisling, they mentioned, they want to know, is there a tool out there? I heard something about an app that allows for some kind of interaction where you can search and tag the MACRA rules. He said he saw something in a tweet that may have even referenced your name. Does that ring a bell to you at all?
Sorry, you broke up a little bit in the middle. What was the tool supposed to do?
A tool that allows you to search and tag within the MACRA legislation itself and kind of interact with the rule.
Oh, that'd be cool. We don't have that, but I should talk to people about whether we can do it. You can do Control F. That's what I've been doing, and then just taking screenshots and posting it on Twitter. But to tag and be able to post more. Let me talk to our tech team and see what we can do. That sounds neat.
All right. And the other question that came through was on that $20 million annually for the technical support. They want to know, how are organizations actually being selected for that funding?
Yep. So pretty soon after we issued the request, or the NPRM, so the proposed rule, sorry, it's an acronym, I broke my rule. We we put out a request for proposals for organizations to apply to receive the 20 million to be on the ground. So we actually had a huge number of organizations apply. I don't have the numbers on my fingertips, and we're currently going through the typical government process to put together a board and analyze their applications. And we should be making an announcement about who received those, who won fairly soon. So keep close eyes. We'll be announcing who were the winners very soon.
Gotcha.
And just from a business opportunity perspective, just from that point, is anyone who's interested, those will be public, of course, in a list. And if you're a contractor or if you know this area really well, you should reach out to those companies that won the deals, and they often will subcontract out to others as well. So it's good to keep an eye on that.
Gotcha. And then, Ashley, once those winners are announced, how does the end practice actually gain access to that technical support? Is it something like they put in a request, and if their request needs somebody to be on the ground in their office, that's when they'll dispatch?
Yep. So what I would do is the easiest way and the centralized way to get any sort of requests for help or questions answered is by going to the qpp.cms.gov site. There's our email address is easily qpp@cms.hhs.gov. Submit an email, and we'll get you on the list. The one thing I want to clarify about the 20 million is that the organizations will be specifically focused at practices in rural areas, practices in I'm blanking on the specific term.
Hospital shortage or health worker shortage areas?
Yeah, health worker shortage areas, and then practices that are under 15 and under. So 15 clinicians in the part of the practice are under. So just know that. But if you don't fall into those categories, there's already help that's available to you. We have a fact sheet on our site that is where to get help. But we have these quality networks where there are different associations and organizations that get together and are they're trained to help. We have webinars that are starting next week. We have a webinar on Wednesday that looks like we're going to have upwards of 10,000 people on it. So we're a little nervous about that, but we're excited to get the word out. We are, and then we have, we have the call center, and we have other areas for people to get help. So lots of ways to do it. Looking forward though to getting that 20 million put to good use.
Awesome. So the last thing I want to ask you before we break off and get tweet chatting here is, what is the press not picking up on? Is there anything that CMS is doing or anything that you want people to know that you don't think is getting the attention it deserves to this point?
I think the main thing that I've seen confusion about online is that people think that this is going to be some horrible, very burdensome change, especially in comparison to PQRS and meaningful use. Just the basics here, I'm just going to clarify it for everyone. It has half the requirements as PQRS and meaningful use. We cut it in half. So that's one. Two, we hear a lot about people being concerned that it's budget neutral, that in order to have any sort of positive payments going out, we have to take away money from someone else. That's just it's a misnomer. I can see how it got developed through kind of the writing of the law, but here is just what we estimate for the first year. We estimate about $1 billion in additional Medicare payments. So beyond what you typically get for your fee-for-service, there's going to be $1 billion going out the door in additional Medicare payments to clinicians. And then we're thinking that there's only going to be about like 300 million or so in negative payments. And those negative payments are only going to go in that first year to people who don't report. If you don't do anything in this program, you don't get anything. But if you do something, you're most likely to either get, your payments are going to stay the same, or you're going to get a bonus. And where the $1 billion comes from is one, we have $500 million each year over the next 6 years, so $3 billion in total from Congress to give to exceptional performers in MIPS. We think that there's going to be a ton of alternative payment models that people can be a part of. We think that 125,000 clinicians are going to be a part of alternative payment models in the first year. We think that number is going to grow a lot in the second year as more models become available. And so you get a 5% bonus for being part of an alternative payment model. And then on top of that, we have the positive payment adjustments from just being in MIPS. So would push back against the budget neutrality point, push back against that it's more requirements than PQRS and meaningful use, and really just want people to know that we're here, CMS is listening, and that we issued this final rule actually with a comment period. So we're asking for specific comment on some areas, including virtual groups, which I saw that you flagged in your blog post. So, we are looking for input. We're trying to get this right. It's a big change. We know that, but we think it's worthwhile to move people towards value and to work with people to move towards value. And I think the whole healthcare arena has been trying to move this way for a long time. We want to help people to get there even faster.
That's great. Thanks for that. And so I do want to wrap us up here. This has been great though. And as always, I think we could go on for another hour or so. And there's so much I want to ask you. But I just want to say in closing, again, thank you for the work you guys are doing there. You got a really hard job. It's a law that not everybody likes, and you've got to implement it. I think you guys are doing a great job, as she had touched on, of talking with people and taking the feedback. And I think the final rule makes it clear here that it wasn't just listening to the feedback. It's clear it was internalized and made an impact on the law. So that should be further encouragement for people to continue to give that feedback, to continue to reach out to CMS, and we certainly encourage everybody to do so.
Thanks a lot. Thanks for having me.
All right, awesome. So thank you everyone for joining us. We're going to wrap up, and we'll see you next week.
Bye all.
Bye now.
Bye.